Thank you for joining us. And did you know that 1 in 3 Missourians have been impacted by opioids, and 6% of Missouri teens self-report misusing prescription medication? And this is just in the last month. Opioid misuse and overdose place a tremendous burden on the families, communities, and healthcare systems. I'm here today on behalf of Missouri Department of Health and Senior Services. And during this event, we'll be discussing how to communicate with youth about opioids. Now, look, if you want to learn more, go online right now to time2actmissouri.com. That's time2actmissouri.com. So I'm going to talk for a few minutes about the way to approach young people on mental health topics generally, but particularly on the topic of opiates and opioid abuse. And then we're going to go into a little PowerPoint, and that presentation is to make sure you know what you're talking about. So one issue is how to talk to teens. The other is what is it you're going to talk to them about. We're going to, first I want to talk to you a little bit about how we approach them, and a little bit about me. I've been working in the field of addiction medicine since 1985. And I became the director of a hospital-based chemical dependency treatment program in 1991. And I have been dealing with the opioid problem and screaming about it for 20 years. So I want you to understand and sort of see it from my perspective. And in order to do so, we're going to have to review a little history. We're going to have to review a little bit about what the nature of addiction is. We're going to talk a little bit about the difference between dependency and addiction. So many opioids are being prescribed these days that we're actually seeing people that get strung out on opiates that aren't even addicts. They aren't true addicts in the sense that we can take them off the drugs. They don't want to do them anymore, while an addict will be interested in continuing. Both can have fatal consequences, particularly in this day and age of the use of fentanyl, which is, you should know, it's dripping into everything. So these synthetic opiates like fentanyl are literally becoming distributed as almost every other compound you can imagine. And kids are inadvertently getting into these drugs without even knowing they're getting into opiates and opioids. And you may hear the term opiate and opioid. They are essentially the same thing. Opioids are synthetic drugs that bind at the endorphin system, the euphoria system, the pain modulating system. Opiates are the morphine-based products and their derivatives, codeine, morphine, that again, what opiates are the pain medications. They bind at the receptors in the brain and the spinal column that are associated with the modulation of pain. By themselves, they were a great breakthrough because they don't hurt anything. Opiate, the drug itself, is harmless. So I want to talk to you a bit about the history, about how when it was invented, doctors thought they'd found the Holy Grail, but they didn't know that there was this dire consequence of addiction on the other side of it. And now that we've gotten into more and more and more powerful opiates and opioids, even small amounts can result in respiratory depression. You stop breathing and you die. So in terms of talking to young people, first of all, be rigorously honest. Do not mince words. Do not distort. Do not be inconsistent. One of the things about health messages to young people I've noticed for many, many years is that you have to be honest. You have to be honest, and if you are hypocritical, if you say, or if you give them inconsistent messages, like, hey, you can smoke cigarettes here, but not smoke them there, they will smoke them everywhere. You have to be very clear on the boundaries, very consistent on the messages. Don't overstate them. Don't fall victim to what I call the reefer madness syndrome, which is you overstate things and to sort of try to scare them into managing their behavior. That goes bad. You may scare them into changing their behavior for a short while, but once they learn that you have overstated things, they will go the other way and you will not get them back. They will not listen to you anymore. So in terms of how you approach, well, matter of fact, narratives. So narratives are very important. If there's some story out there you've heard or read about somebody who ended up in a bad place because of their opiate, or maybe their child knows somebody who's ended in a bad place, you sort of either bring that kid into the discussion and let your child hear that conversation or talk about that story. Narratives, relatable source. So that's a relatable source, right? It's another kid. It's like them who died or overdoses or maybe survived it or had to get treated, whatever it might be. So it's narrative, relatable source, and use a little humor, right? Try not to, it can be a little difficult to bring in humor into stories like this, but lightening it up a little bit can really help them hear the stories that you want them to hear. Now, in terms of identifying kids at risk, it's not as though there are pathognomonic signs out there. There's not as though there's one thing, you got some problem with opiates. Most kids get their first opiates from the home and friends, okay? They go into your cabinet or grandma's cabinet and they see some opiates left over there from a past root canal or something. If you don't treat those opiates with the seriousness with which they should be treated, they will not treat them that way either. So do not keep old prescriptions around for opiates or benzodiazepines, the Valium-like drugs. I'll talk about that a little bit later. So be sure that you treat if you do anything, put them under lock and key. If you're going to keep them around, go, these are very serious. We're putting them in the safe. These are not to be touched. Don't leave them lying around. Remember, many kids get their exposure to their first opiates from friends' houses, family, coworkers, things like that. But family is a very common place for them to get their opioids. So if you have a kid who's getting into this, there can be no signs. This is one of the challenging parts about opioids. They're very occult. Now, any mental health problem in adolescent and young adulthood tend to present in very similar ways. Opiates, of course, are similar in that respect, in that if a sudden drop in grades, if this is a student, the number one sign that you have a mental health problem is a sudden drop in grades. Look out for that. Do not consider a sudden drop in grades in a child that was previously doing well. Do not consider that a parenting problem or a scholastic problem. First, look at the mental health. Secondly, changes in appetite, changes in sleep patterns, changes in how they dress, changes in their peers. These sorts of things can signify that a mental health problem is underway. And when kids are using something like opiates, they're often using other stuff as well. So, and you need to kind of understand why kids do drugs. And we'll get into this a little more as we go through the PowerPoint procedure, the PowerPoint that I want to present to you. And it may be a little tachistoscopic. I'm going to move a little bit quickly through this because I want to get to your calls. We're going to get to calls in about 40 minutes or so, and we're going to answer your questions very specifically. But as I was saying, people use drugs to feel good or to feel better, right? Those are the two reasons people use drugs. They use drugs because they work. And they're either trying to feel better because of a psychiatric symptomatology, the most common thing being trauma, and we'll talk about adverse childhood experiences in a minute, or to feel good. They are partying, they're out there, they're listening to their peers. A lot is made of peer pressure, but I'm telling you, the biggest issue is not so much the peer pressure itself, so much as kids looking for solutions to internal problems. Again, we go to calls. If that doesn't make sense to you, I'll be happy to refine that further. But if a kid, and I'm not just talking about depression, I'm talking about feeling badly. Unregulated, negative, prolonged affect, we call that. And then, again, that is the consequence, typically, of what we call adverse childhood experiences. So we will get into that. So let's get into it. I thank you for being here. Those are my openings, and let's just get right into the PowerPoint if I get my first slide here. And I want to do just a very little review of history, if I might, because of what I've got up here is that if you don't know history, you may repeat it. So this is just about Dr. Benjamin Rush, back on one of the signers of the Declaration of Independence. The important thing that he brought up all the way back in the 18th century was that there was a disease model to addiction. Addiction is something that has a genetic basis to it, of course, environmental as well, but it is something that fits the model of disease. And I'll talk to you what that is in a little while. And that the way to approach any addiction or disease, he was specifically talking about alcoholism particularly, but he was saying that there's a necessity for abstinence. And there is, in fact, you have to be abstinent. But in the 19th century, we got smart and started creating more substances. We started creating morphine. Dr. Friedrich Sertner produced the substance morphium, named after the Greek god of dreams, and he experimented on himself and 3 boys and 3 dogs and a mouse, and all 4 people he studied almost died of this. And opium was around for many, many, many years, but morphine was supposed to be a better, less addictive form of morphine. You'll notice a pattern here in the history that medicine is always looking for a non-addictive opiate. Do not consider anything a non-addictive opiate. That's the tale of this story of medicine. And then it was marketed to the public as a pain medication and a treatment for opium addiction and alcoholism. So think about that. Morphine, when it first arrived, was a treatment for opium addiction and alcoholism. Well, of course, He just made more addicts. And eventually he became addicted to morphine, and he's finished his life warning, "I consider it my duty to attract attention to the terrible effects of this new substance I call morphium in order that calamity may be averted." Well, here we are nearly 200, well, over 200 years later, with the same calamity on our hands. But I'll tell you how we got to this one. But when they developed morphine, I mean, this was a big deal. In a real sense, medicine had a breakthrough. I mean, doctors were overwhelmed. This had a profound effect on doctors who, for the first time, were able to relieve suffering, which is about all doctors were interested in those days, because they really couldn't do much in terms of disease processes. And then the consumption after the Civil War increased. A lot of it was the trauma of war. And of course, there was a technological advance following the Civil War as well, which was the hypodermic needle, being able to inject morphine. And magically, guess what? As you could present it parenterally, we call that, in higher concentrations, you got more addiction. And there was a ton. The doctors were overwhelmed with all their cures of pain, and they were going to, they had all kinds of proprietary cures, and these guys were peddling the stuff out of trucks and wagons and things. And it was even in paregoric for babies. Look at this, 5-week-old. Look how many you give it for a 5-day-old, a 2-week-old, and a 5-year-old, giving them opiates, paregoric. And of course, alongside of that, we had cocaine. So we were doing, within medicine, we were very interested in these compounds. And there were few effective alternatives. So doctors resorted to morphine. But the disease of morphine, again, it was a disease, and the majority of cases were initiated, sustained, and uncured by members of the medical profession. And then in 1874, nearly 70 years later, we have a doctor messing around with this, trying to look for another cure now for morphine addiction. And he put the morphine anhydrous morphine alkaloid with acetic anhydride and created diacetyl morphine. And this was marketed by the Bayer Company as a non-addictive morphine substitute and cough suppressant for children. You know it as this drug. So here we are again with the medical profession creating stronger and stronger and stronger biologically active agents that caused more and more addiction in the name of treating addiction and pain. And look what they were saying about it at the time. In 1900, the Boston Medical and Surgical Journal proclaimed, "Heroin is not a hypnotic. There's no danger of acquiring a habit." Drug kits were readily available to consumers. The kits contained a hypodermic needle and vials of heroin. So be careful with these substances. I told you at the beginning, treat these things like they are seriously dangerous compounds, because the medical profession may not necessarily alert you the same way. And I just want you to know that the Harrison Narcotic Act came out in 1914. This was really designed to make sure physicians didn't continue to prescribe replacement therapies, because doctors were replacing one opiate with another. And that was the original. It really wasn't so much a prohibition law, but then there were some Supreme Court interpretations that followed that made it a prohibition. And it is still the foundation for the law of the land of how we treat illicit substances. And of course, at the time, it forced addicts to get drugs by any means, and physicians were put by the thousands into prison for violation of that law. Well, I just want to give you a brief sketch of how we got to the modern problem. There was a convention on narcotic drugs declaring that the medical use of narcotics was indispensable to the relief of pain and mandated an adequate provision of narcotic drugs for medical use. Now, you got to understand, after the Harrison Narcotic Act was initiated, there was a general sense that opiates should be avoided. Well, in 1961, they started really thinking otherwise about this. And in 1981, there was Dr. Catherine Foley, who came into the 70s, became a voice for cancer patient and pain control. Appropriately, we could use newer opiates for the management of pain and cancer. But they started broadening out how they used it. And they started partnering with the drug companies, and the Purdue company produced MS Contin, and then Dr. Foley helped push the Palliative Care Act. It's a new discipline that her protege, Dr. Russell Portnoy, declared gave him the talking points I needed to mold my work. To Portnoy, these were revolutionary advantages. And then he published this article, Dr. Portnoy did. And what he said essentially is that in hospitalized patients, you don't see addiction if you used opiates. That's about all it said. And then there was this famous letter It's a 1-paragraph, 5-sentence letter to the New England Journal of Medicine, which concluded the widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. Now, of course, this was used to, this is the entire letter, in fact, right here. We conclude that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. There they are. And this became the justification for the widespread use of opiates. There are 500 citations out there. They neglected to note that the letter concerned itself only with hospitalized patients in a structured time-limit environment, and it became the beginning of the opioid epidemic. And then the pain management folks got involved, and they started a zeal. They started a religious fervor. Watch out any religious fervor in scientific areas. We're seeing so much of this today around COVID-related stuff. It's the same thing here. 1996, this is the President of the American Pain Society. If we assessed pain with the same zeal as other vital signs, it would have a much better chance of being treated properly. So pain became the 5th vital sign, as important as your pulse and your blood pressure. This was an insanity that gripped the medical system, and the JCO, all the regulatory societies, the California legislature, the California State Board, all these different organizations jumped on board and mandated pain the 5th vital sign. And it was on. It was on. This is a pain management doctor who points out that it was not only okay, but it was our holy mission to cure the world of its pain. Unbelievable. This is, once it became clear that pain patients weren't going to become addicted, now we were liberated to use that solution that had been in the hand the whole time. And then we have the insanity of this lower quote with someone reported that their fellowship director told me, if you have pain, you can't get addicted because opiates soak up the euphoria. This is what was going around, and this is why pain management and the distribution of opiate became massive. And of course, they saw the drug companies, Purdue particularly, that they'd done everything right. They had supported the clinician, they supported education, they'd done everything they should have done, and this was the partner, the handmaiden in all of this. And then, of course, the attorneys got involved and started putting doctors now in jail for inadequate treatment of pain under the moniker of elder abuse. This happened. This particular case was, I think this was in California, and then another case in North Carolina. So now we're putting doctors in jail or gigantic sums of, this is not malpractice, this is criminal and civil indictments in the name of inadequate treatment of pain. And that was it. Pain became what the patient says it is, and that was it. Doctors were prescribing excessively. And this was something I saw from 2013, and they still were insisting that 35% of patients may have trouble managing opioid intake, but consistent with prior studies, it's false to conclude that this number equates with the prevalence of addiction. So denying as recently as 2013 that the distribution of opioids results in addiction. And again, despite these sorts of studies that showed there was no long-term efficacy for chronic pain, chronic non-cancer pain. And pain causes withdrawal and hyperalgesia and addiction and tolerance, and it's a mess. And look, this is what started happening. Because the medical profession was pursuing pain management with such aggression that, lo and behold, drug deaths started going up, overdose deaths from opiates, now heroin. Towards the latter part of the 2015 to 2020 window, doctors started getting the message that oral opiates are not such a great idea, that maybe there's some untoward consequence of all this. And they cut the patients off. And guess what they did? They turned to heroin. They just went to heroin. Because you can't cut somebody who's strung off on opiates and just cut them off and expect them not to continue. It's just not the way it works. They will then go to the street and then they will get other drugs. And of course, as I mentioned in the opening, these synthetic opioids, fentanyl, started coming in, and this is an extremely dangerous phenomenon. Fentanyl, the difference between a dose that gets somebody high and a dose that kills somebody is essentially impossible to determine. So people are inadvertently dying even when they know they're getting fentanyl. And fentanyl commonly comes in as other substances, things like Xanax, which is a benzodiazepine medication. And it's killing people without even understanding that they were exposed to fentanyl. This is happening all the time. And again, I just want to point out here that if you're going to take an oral opiate and die, it's really hard to die of an oral opiate overdose. you can get out of it pretty good, but it's only IV or only fentanyl that's going to kill you. The other drugs, the Vicodin, the Oxycontins, the other hydrocodone, all those things we're used to hearing about as pain medication, really hard to die from overdosing on one of those, unless you take it with a benzodiazepine. So that's a Valium-like drug, Xanax, Valium, Klonopin, even the sleeping medicines like Ambien. So any combination of those can result easily in a fatal overdose. And I just want to point out here that we're talking about opiates today, but the hidden drug in all of this epidemic is the benzodiazepines. That is raging along. Physicians begin to understand that the opioid prescribing was out of hand. We have curtailed that on the prescription side, though the heroin side and the fentanyl side continues extraordinarily vigorously. But out there as well are the Xanax, the Valiums, these other drugs, and it's being overprescribed, much like the opiates were, and it's being widely distributed. And this is just an article that points out that in hydrocodone, oxycodone deaths, there's almost always, 96.7% of time, multiple drugs of abuse, primarily benzodiazepine. And again, this just shows the combination of opioid involvement with the benzodiazepine overdoses. And here we are again. These are a little outdated data, but you can just extrapolate those numbers straight on up. So let's talk about what else goes on with young people as it pertains to substances, right? There's a lot of overlap between mental health issues and substance use disorder. Virtually any mental illness you can mention can have a concomitant relationship with substances, because young people see the drugs as solutions, as I said earlier, to feeling badly. They want to feel better. And certainly these days of re-regulation of cannabis and alcohol availability, they reach for the solutions that society gives them. And there's a lot of co-occurring phenomenon of mental illness amongst substance users. For instance, as I said, affect dysregulation is the common feature that motivates somebody to use drugs. Causal effects of the drugs. The drugs themselves can induce, we're talking about primarily about opiates. Opiates aren't as common to cause mental health symptomatology as, say, the stimulants like methamphetamine or cocaine. Meth is in there with the illicit opiates a lot these days. So if you have someone who is manic-y also, who has a manic meaning that they have flights of ideas, they're not sleeping, they seem grandiose, they seem a little irritated and agitated, and they're taking opiates, expect that there's a stimulant in there, typically methamphetamine. And the common core cause of mental illness and substance abuse can be shared. Now, this is the other thing I want, when we're talking to young people, I want to point out that adverse childhood experiences are exceedingly common in our world today. And I'll explain to you what the particular adverse experiences are. But when you're talking to young people, a self-assessment can be very important. In other words, look at what kinds of history you've had as a child. Were there things you were exposed to that were traumatic? And as you see here, as you go from 0 to 4, the risk of depression goes up. As you go from 0 to 4, the risk of alcoholism goes up. This is in adulthood. And again, the ACE score there is related to drug problems. The ACE score goes up, drug problem goes up, suicide probability goes up. Really, when you get up around 4 or 5 adverse childhood experiences, the risks of severe substance and mental health issue go up. And look, here are some of the things to think about. These are the issues that a lot of people don't think of as related to adverse childhood experiences. So a parent, a broken family is an adverse childhood experience. Let's look at that. Be aware of that. A family member incarcerated is an adverse childhood experience. A family member with substance or mental illness, even if it's not unmanaged, just having that in the household is an adverse childhood experience. Emotional abuse, of course, is an adverse childhood experience, but people don't recognize some of the things that happen to them as emotional abuse. And physical abuse, I mean, that gets excused all the time as just discipline. Let's be clear. A great way to a dividing line between discipline or getting carried away with discipline versus physical abuse is when you pick up an object. Once an object is picked up, that has a different effect on the brain. It shatters the upper regulatory limit of the brain's ability to regulate. It also changes the way that child will then trust and connect with other people. It's a fact that how we develop our ability to regulate I put a couple notes about this here. There's a whole biology of attachment and the result of rupture of that attachment for abuse and how it results in emotional dysregulation and then the drug-seeking behavior later in adolescence and in young adulthood. Now, I can get into the details about this later if you wish, but I just want to point that out there. And of course, this is just another reminder of what happens throughout the lifespan as the result of adverse childhood experiences. This is it. And be careful. There can be historical and generational effects here, social conditioning, and disrupted neurodevelopment as a result. And then you result in disease and early death. This is a direct relationship between what happens in childhood and how the medical and mental health of the individual plays out. So let me do a couple minutes here. Again, as I told you, I'm flying through this a bit because it's like you've asked a cardiologist to come in and talk about the heart. There's a lot to know about addiction and drug use, and I'm going to try to keep it as digestible as possible. This is just I want you to understand the difference between addiction, which is a disease, and drug substance abuse or substance use disorder or dependency. Don't conflate dependency and addiction. If you're an addict and you use for long periods of time, yeah, you will get dependency typically, but addiction is about a progressive disorder that has a genetic basis to it. And I just put up here, this is my definition of disease. A disease is a relationship with the environment and the genetics of the individual that results in abnormal physiology that is shown to be present with signs and symptoms. Those signs and symptoms follow a natural history, and that natural history can be altered by somebody like me with something we call treatment. That's it. That's disease, all disease. And you will see that addiction fits this model quite nicely. Again, genetics, environment, so genes aren't destiny. Generally speaking, when it comes to mental health disorders, about 60% of the presentation is accounted for on the basis of genetics alone. There's a guy named Mark Schuckett that studies this very carefully. This is how he says it, particularly as it pertains to addiction. I found it to be true of for the most part, of other mental health disorders as well. About 60% is accounted for on the basis of genetics alone. And then there can be some environmental hit, adverse childhood experiences, then the brain chemistry changes, then you have signs and symptoms. They progress in a predictable way, that natural history, and then we try to change that with treatment. And this is just to show you the parts of the brain that are involved in addiction. Of course, it all has to feel good, right? That's why you use drugs, they feel good. But this part about, there's two different systems in the brain. There's a wanting system and a liking system, okay? You have to like the drug to want to use it in the first place, so people like it. And you have to be kind of genetically set up for that too. I mean, a lot of people don't like alcohol, they don't like pot, they don't like how opiates make them feel. I know I get dysphoric from opiates, which for my opioid using patients is astonishing and unbelievable. And then there's the wanting part, that you want it even when it's not working for you anymore. And there's a complex biology behind that. Again, if we want to get into more details about that, this is, again, it all converges on a part of the brain called the nucleus accumbens. Even the shell of the nucleus accumbens is where a lot of this biology and genetic changes go on. Essentially know that what this slide is showing us, that it comes in through various pathways, and you see the opioid peptide in there at the top middle. It comes in and it changes the biology of this deep region of the brain, right? Your brain is sort of constructed on three levels. There's your conscious cognitive system, which is complicated in itself. There's a lower system, and then there's a deep system. The middle system is sort of the emotional feeling centers, while the deep system is the drive system, the motivational system, the wanting system, and that's the part that gets overtaken with addiction. Now, again, I want to say, you look at the family history, that will tell you oftentimes whether the risk is there for addiction, because it's a genetic disorder. So is there a first degree relative with addiction? If there is not, and somebody still looks like they're using compulsively, don't consider it any less of an urgent issue, because you got to get them off the drugs, particularly with these particular drugs we're talking about, because it's so easy to overdose. And I just put this up here to show that it sort of shifts in where in the brain the predominant biology of this disease takes hold, and how later, as you get into the absent relapsing phase, there's sort of a different kind of biology that kicks in. So let's talk about how we define addiction. I use a plain old-fashioned definition that we used many, many years ago. I just say addiction is a biological disorder with a genetic basis. The hallmarks is the ongoing use in the face of adverse consequence. Adverse consequence means effects on school, work, relationship, health, or finance. And then denial. And denial is extremely powerful. I have an hour lecture on denial itself. Denial is a complicated process. In the setting of drug using, it's so powerful it has a biological component to it, where literally the addict can't see what's happening to them. Look on the streets of our major cities. All those people in tents literally don't see that the addiction has driven them there. And the DSM-5 has sort of broken things down a little differently into substance abuse and substance dependence. And they were merged into substance use disorders, right? And the severity of the substance use disorder is either mild, moderate, or severe. And it divides substance use disorder into two categories: harmful pattern of substance use and substance dependence. So again, they no longer are using the terms that I like using, like addiction. They use substance use disorder, and it's either with just substance use, with or without dependence, and the severity and how it's manifesting is really how people look at it now. Again, why do people use in the first place? This is the part that you want to talk to kids about. Well, first of all, those genetics. You got to pay attention. If you have a child who is at risk, if family members are an addict, again, it's about, generally speaking, whether one or both parents are addicts. If one or both parent is an addict, it's about a 50% probability, as I said, 60% on the basis of genetics alone, but it's about a 50% probability that that particular child will inherit this potential. And again, part of it is that the drugs feel good when you use them. And the other reason, as I pointed out several times, the other reason to get involved is the dysregulation. That's what they're looking for. They're trying to feel better. And this is just a point that the biology gets increasingly complex as we go through it, but that it changes the brain in significant and sometimes permanent ways in the setting of addiction. And of course, the frontal part of the brain, the part that we use to make judgment, the part that we as adults have developed, I don't know if you're aware, but the frontal part of the brain is where executive functioning resides. Young people don't have that on board yet. They're relying on your frontal lobe to superimpose upon theirs, but addiction breaks that down even further for them. Now, I just want to point out, this is a friend of mine who runs the Harvard program on addiction. We're talking about what you can do about it. 12-step. 12-step is available on every corner, and he is now, Dr. Kelly, this is Dr. John Kelly, he now has a meta-analysis, Cochrane analysis that shows that 12-step, which is free and available everywhere, has the equivalent efficacy to any other professionally managed treatment. So oftentimes, just introduce AA, NA. It can go a long way if somebody is really struggling. Now, that is not to say they should not be in the medical system. If somebody is dependent on opioids, they've got to be seen by a doctor. They have to be managed in terms of their withdrawal. We can talk about how to do that. Again, mutual aid societies are available everywhere. Now, they may not be, there's some disadvantages. There's no clinical oversight and there's no quality control, but the recent data suggests that this is an important alternative. And one of the ways that we have of getting people into those mutual aid societies is introducing them to somebody who is already from that program, the so-called warm handoff. In this particular study, this was sort of an emergency room, physicians who were giving recommendations for somebody to go to a 12-step meeting. They essentially said, here's some pamphlets, here's a meeting, I want you to go. 0% of the patients went. Then the other group was a individual from the 12-step meeting, walked into the room, shook the hand of the individual, said, I'll meet you at the meeting tonight. 100% of those people went. So that tells us how we can get people involved in these things. And this is something I just want to remind people that it takes a long time to really get sustained abstinence. This is, again, from Dr. John Kelly, and 8 years and 4 to 5 treatment episodes to attain 1 year of sobriety when somebody has severe addiction. So that's something to keep in mind. Just stay with it, stick with it. Oftentimes they have periods of abstinence, but they go back until they get finally that sustained abstinence. Now, I've been asked to talk a little bit about stigma. These are the kinds of stigma that are out there. This is just the nomenclature. The important one is really the public stigma is us, right? The self-stigma is the important part of this. The internalized stigma or self-stigma, they're essentially the same thing. And understand that we may understand that people are stigmatizing of addicts, that we sort of all kind of know that, but addicts don't necessarily experience that much stigma. The families do. The families do. So self-stigma can just be an internalization of the public or the experienced stigma. And it's defined as a process as either conscious or unconscious, where the person with a mental illness accepts diminished expectations both for and by him or herself because of this stigma, right? I am less than, I can't be relied on. And addicts do get into some of this thinking, much because they know that's where the disease takes them. The problem is with addiction is because of the motivational disturbance, they don't care. The addiction the use takes over as the priority in all cases. Now, people can deal with stigma. This shows that you can react to stigma in different ways. And this is for anybody with mental illness. And I think this is an important topic. You can either lose your self-esteem and self-efficacy, mind your ability to do things. You can be energized by prejudice and mobilized to express righteous anger, or you can either lose self-esteem or become angry, instead ignore the effects of published prejudice altogether, which is sort of number 3 where the addicts end up. The healthiest is number 2. People, they can internalize the stigma, but some are energized by these same stereotypes and become empowered in reaction to them. That when they come to understand their disease, they want to be a role model for other people. They want to speak out on behalf of their illness, and this really reduces stigma. And so stigma can become, let's say, motivating, mobilizing. Watch out, though; they can internalize it, and it can suffer reduced self-esteem and lower self-efficacy. And the thinking is that there's a meteor of that paradox of how you go one way or the other. You have a positive identification with your stigmatized group, you feel empowered, and then you get increased self-efficacy. Okay, those are, oh no, I've got a little bit more here. I just wanted to say that that there are treatments out there, so-called, you'll hear about replacement therapies for the treatment of addiction. And this is a very complicated field, okay? This is the first data for some of the first publications. This is 1978 on Suboxone, buprenorphine. And at that time, they were saying there was little, remember this story from the history I told you at the beginning? Here we are again with addicts going, this has little, if any, physical dependency, low abuse potential, patients love it, and they're easily detoxified from it. None of that was true. It turns out that you can get addicted to Suboxone and buprenorphine. It is somewhat difficult to get off if you've been on it for a long period of time. So it does have a lower abuse potential than some of those other drugs, so it has to be used very, very carefully. The point being that you're going to hear about Suboxone. It is a good drug. It's a detox drug, particularly if people have limited resources. It can allow for opiate detox as an outpatient. And but it's a little bit controversial in terms of whether you leave somebody on it or not. There's no doubt that the presence of Suboxone has revolutionized the treatment of opioid addiction and even opioid dependency, because it can use to wean somebody off opiates. It's an excellent drug for short term. Whether it should be used long term is a more difficult call. Only doctors with very specific kinds of clearances can prescribe this drug. It's called the X clearance from the DEA. I have one, and yet I use this drug very, very cautiously, because when people get strung out on it, it can be as much of a problem as anything else. Though, if you can get it down to very, very low doses, which is, again, easier to do than some of the other opiates, people can have long-term well-being and sense of return of productivity and back to a good, thriving life again. And you got to think about what is it we're looking for. Oh, by the way, this is about naltrexone, which I'll talk about in a minute. This is just saying that naltrexone is another what's called medical management for opioid addiction. There are medically assisted therapies out there. Suboxone is one. Naltrexone is another. I'll talk about that in a second. And again, we're looking for people to restore their life completely. You got to be careful. It's not if you have the disease of addiction, again, dependency, somebody without the desire to keep going with this, they generally do very, very well and very quickly want to restore their life. And people who are early in their use of a substance that don't have the genetics of addiction, if you warn them about the problems, if you help them talk to them about what this thing is and learn, share with them what you've learned today, and again, use a narrative and be very honest with them and be very forthcoming and matter of fact, they may turn the corner and decide not to use these things. But if you have somebody who is already strung out and does have the genetics of addiction, we want to get them into full recovery where they can regulate their emotions so that that adverse childhood experience material isn't there fueling them to go back, and that we kept them off the substances long enough that they don't have the biology of the drug operating driving them back as well. We want to get them employed, get them regulated, get their life skills back, and have them really not just off drugs, but thriving, a full recovery, flourishing. And so that's what we're looking for. It's a certain kind of life they have to lead. Flexible affect regulation is what we're looking for. The ability to live your life without substances. So those are my basic remarks for what I want to talk about formally. Again, I want to talk about take more of your questions. I want to get to that in just a second. We're going to have a conversation opening the phone lines. The number is 984-2-DRDREW, 984-2-Dr. And do not forget, for help and for treatment, training, more initiatives, Missouri has great online materials. You can just go to time2actmissouri.com. It's time, number 2, Act Missouri. I was fishing around on the Missouri sites, and there really is a lot there. And so some of the comments I made, I didn't want to be just recapitulating what's there, because it is all there for you to digest. I'm hoping this gives you a little more added material beyond what is there available. And this is something I want to really emphasize. If you witness an overdose, now, the Missouri Good Samaritan laws protect people who call 911. They protect them from arrest or prosecution for possession of drugs or paraphernalia. So do not run. Call 911. Don't run away, okay? So what are the signs of an overdose? If somebody is unarousable, okay? If somebody cannot be aroused, or if they seem to be struggling or choking, or if this is a medical emergency. This is how people die of opiates. So if you have somebody who's using substances, they're slumped over and not arousing, you're not in a position to make any other assessment than that. Call 911 and get them help. The police will not make you accountable. You have a Good Samaritan law in front of you. And you should think about, if you're in and around people who use opiates, you should have naloxone or Narcan. This should be in everyone's first aid kit. In many states, it's available over the counter without a prescription. Yes, in Missouri, I'm looking at my notes here. It is available in Missouri without a prescription. And you should carry it with you. The Surgeon General of the United States said we should all have this. I carry it in my car. I carry it in my coat, because the opiates are so common now that you are likely to come upon somebody who is not arousable or not breathing, and you can save their life like that. You got to be aware of this. You have to take it with the urgency that it's appropriate for what this is. Again, naloxone, the way it works is it's a nasal spray. There's also injectables and other things. There's also in long-term oil-based injectables that you can give people again, as part of the medical management of opiate use. Talk to your doctor about that if that's something, again. And how it works is by blocking the effect of the opiates. So opiates bind at these endorphin receptor sites. Many people have heard of endorphins. It's the part of the brain that is sort of the euphoria, feel-good part of the brain, and that's where the opioids have one of their primary effects. It blocks that. Naloxone blocks those receptor sites so the opioids can't bind. And if you've overdosed, it has a more powerful binding affinity at those receptor sites, so it knocks off the heroin or the fentanyl or anything else that happens to be at those receptors that are causing decreased consciousness and decreased respirations. So let us go to the calls. Again, the number is 984-2-Dr. Drew. And again, don't forget, go to time2actmissouri.com for more online information. So... Here we are. Can you hear me okay? There we go. I'm going to take some calls here. I appreciate you guys calling in. I hope this was useful for you. We'll go first on to Sarah. Hey, Sarah, what's going on there?
Oh, hi, Dr. Drew. Thanks for taking my call.
You betcha.
So I kind of have a two-part. I have a two-part question. So I have a history of mental illness in my family.
Mm-hmm.
My dad actually was bipolar,
mm-hmm.
and I have two small children. So what concerns me is, what is the risk of them having, how does it increase their risk since I have mental illness in my family? And then also, they're 4 and 7 years old.
Right.
At what age do I actually start having a conversation with them that they're actually going to understand what I'm talking about,
right.
and not be scared or
Yeah.
So that's kind of where I'm
Yeah,
at.
it's not these are not easy conversations, but I feel like they should be had early and often, the way you would talk about any other health issue in the family. Hey, grandpa had cancer, so when you grow up, I want you to be careful with this and screen or watch your diet, whatever it is, and educate about what these things are. The extraordinary thing to me in this country is that we treat conditions, diseases that happen to occur in our skull totally differently that we deal with diseases that occur elsewhere in our body. And the fact is, these are diseases just like anything else. And this is back to that stigma stuff I was talking about a little bit earlier. And was your dad into substances as well, or just bipolar?
No, well, kind of. He actually, it's kind of interesting. He was injured at work, had a back injury. They put him on medication,
Opiates.
and he ended up I'm not even sure. I was really young. He ended up developing schizophrenia, bipolar. He had delusion of Grenier. He was hearing voices.
All right. So let me just say.
And he was sick for about 3 months before he ended his life.
He killed himself. Yes?
Yes.
Okay. So that all could have been addiction.
Yes.
Easily. I can't tell you how often addiction goes undiagnosed as other mental illnesses. The fact that this all could have been opiate addiction, in fact, because when people get the back injury, they get put on the opiates. I didn't go into detail about it, but I was talking about the chronic effects of opiates, was they cause back pain from chronic withdrawal. They cause hyperalgesia, which intensifies all pain experience, and they trigger addiction. And so he may have been just an opiate addict. Now, do you feel like you have any momentum with substances?
No, I feel fine in that.
Okay.
I mean, I do have I struggle with anxiety and not as much anymore.
Right.
But
so that's because
my concern is since my kids are exposed to that.
I know. Hold on. I'll get you to it. Right. I get you. That's your anxiety jumping in here. So let's get to it. So the anxiety disorder is the result of the adverse childhood experience of having the traumatizing dad around and the use of substances and stuff. That is an serious adverse childhood experience. And having mood disturbances and anxiety disorders are a common outcome from that. Now, your husband, does he have any addiction to his family?
Yes.
Is he maybe got a substance?
Yes, on his.
Does he have any momentum?
No, I think he's okay. But not. I mean, his family definitely. There was a lot of that in family history.
All right, so you both have that.
And I have substance use in my family history as well.
Yeah, I get it. So you both have that. That's the predominant, as you describe it at least, that's the predominant genetic issue I'm hearing. You could also teach the kids about anxiety and about mood disorders and the types of mood disorders. Just bring it up very matter-of-factly. Just the way you would, again, any other health risk that these children would possibly be at risk for in your family heritage. And then as time goes along, as they get towards adolescence, that's when you got to get more direct and more serious and more, again, don't scare them, but really talk about the consequences. And I will tell you that one of the things that kids will say who have a strong genetic component will go, well, if I'm so screwed up, I might as well enjoy myself. That's addict thinking. And make sure that they are attend to their emotional well-being. And get mental health services early if you see anxiety, if you see mood disturbances, because treatment works. And if you can get them involved in treatment before they start looking for solutions out in the world, that will really, really help things. Okay. And don't treat it any differently than any other condition that you would be seeing a doctor for. Like if they had high blood pressure, we've got to go to the doctor. Matter of fact about everything. Be very matter of fact. Thanks, Sarah. Great call. This is Larry. This is another great question. Hi, Larry.
Hey, hi, Dr. Drury. Thanks for taking my call.
You betcha.
I wondered what suggestions you might make for ways to support the attempts that my child makes to maintain sobriety, especially in family and social settings.
Yeah. So here, I get this question all the time, Larry, and people will say to me, I will do anything to help my child. Just tell me what to do and I will do anything. And what I say is, and let me set it up for you, is that the disease of addiction is exactly like the plant in the Little Shop of Horrors. Do you ever see the Little Shop of Horrors?
Oh, yeah.
Okay. So the Audrey 2 plant.
Absolutely.
What happens when you go in the room with the Audrey 2? Feed me, feed me. What happens to you?
You get eaten.
You get into the plant. That's exactly right. And the only way you stay out of the plant is with somebody there pulling you back. That plant is a perfect model for addiction and alcoholism. And again, I didn't explain earlier, but addiction and alcoholism have common genetic sort of sources. And so they have different natural histories and different kind of ways of manifesting, but genetically and biologically, very, very, very similar. And so the disease of addiction and alcoholism will suck you in. It's an interpersonal disease. So every asset you have as a father, every great instinct that you have as a parent will be turned against you and be used by the disease to maintain the using. Do you understand what I'm saying?
Yes, sir.
Okay. There is one and only one thing to do. Well, it's two things, really. And I tell families this all the time. You can either get your own therapist, again, your own person to be there with you, to keep you pulling you out of the plant, or ideally both. You go to a program called Al-Anon. It's also free. It's also available on every corner. And you get yourself a sponsor in Al-Anon. And whenever you deal with your son, you check in with the Al-Anon sponsor to help change the dance so you don't go in the plant. Because it's it's a brain disease that is so pernicious, and it pulls everybody in with it. And it's cunning. It's cunning, but it can be interrupted with therapy, with some skilled therapist on the outside helping you, or the program of Al-Anon. And Al-Anon is free, and it works, and it really does change the dance. And if you don't do these things, here's the horrible part about all this. If you don't do these things, you're actively contributing to the demise of your loved one. This is what I try to get people to understand all the time. You have one move, and it will make a huge difference. And if you don't do it, you're contributing to the problem. So please do get that therapist or go to Al-Anon. Larry, thank you so much for that call. And listen, your son can do great. He can do treatment. Recovery works. People recover all the time. It's a miracle when it happens. It's a tough disease for them. So here we go. Dan, what do you got?
Well, Doctor, there is a growing body of research in recent years which seems to show that patients who are using opioids reduce or in some cases eliminate that opioid use when they have access to legal medical marijuana. Do you see the use of cannabis as an important tool in the treatment of problematic opioid use?
Yeah. The way you frame your question, I can't answer it, so let me reframe it a little bit, is to say that you're correct that many people do transition to cannabis, particularly since the opioids have been diminished by the doctors. And I would much rather treat somebody strung out on cannabis than somebody strung out on opiates, much. And that's number 2 point. And number 3 point, you're right. Sometimes people do use cannabis as a replacement therapy. And I don't think in terms of good substances and bad substances. They're just these chemicals, and humans have a certain reaction and relationship with them. And if somebody who might have been on, say, Suboxone replacement therapy can get by with cannabis replacement therapy, good for them. But they need to be medically managed, and they need to be watched very carefully. And you have to. So this is the hard part about and this is the hard part of all this, Dan, is that who should be treated with some sort of replacement, whether it's cannabis or Suboxone or anything else, and who should be going for abstinence. This is the key thing, because any substance use in somebody who needs abstinence can really end in a bad place. And by the same token, anybody who needs replacement, who a doctor forces abstinence on them, that can end up in a bad place. So this is where the artistry of addiction medicine comes in. So it's an interesting point, Dan. It's well taken, and that's my sort of take on it. To get back to your question, we don't have the data to formally use it yet, but it will come, I suspect. I suspect it will come. Ariel there. Thank you, Dan, by the way. Ariel.
Hi, Dr. Drew. Thank you for taking my call.
You betcha.
I am a physical therapist student in Southern California, and I'm wondering what your ideas are on the role of me and my future colleagues, in this opiate crisis.
Yeah, it's funny. I saw your call on the board here, and I thought to myself, I can't tell you how many distressed calls I've gotten from physical therapists as these chronic pain patients strung out on opiates essentially become hypoventilatory on their tables all the time. I used to get that all the time. And yeah, I'm sure you see it. You still see people that are strung out. And physical therapy, it has a extremely important role to play because you also know that you can improve pain, right? Particularly things like back pain and major joint pain. So to leave physical therapy out of the sort of the management spectrum of what we do with addicts is a huge mistake. So whether it's a headache patient, and you know all the magic you guys can do with headache, a neck pain patient, a back pain patient, a knee pain patient, you guys, I use you all the time. But I'm going to tell you what, you can't do it by yourself. You have to make sure that the physician is adequately enlightened in understanding what he or she is dealing with to help you get this patient through this. I think a lot of your frustration, and probably the reason you call, is you feel like you're not just treading water, but drowning, right? You're going nowhere. Yeah. And I'm sure you see a lot of that. And that's somebody who's not being properly treated, frankly. I started this lecture by talking about the history of opioid addiction and how we got here. It's my profession that brought the original opioid epidemic at the turn of the century, the 20th century, and it's my profession that brought it to us in the last 20 years. And now it's all out on the streets and everyone else is trying to deal with it. But we have to have people that know what they're doing, and they're out there. But you need to have a team. And another thing, Ariel, don't do this alone. You got to do this as part of a team. This is when I talk to other doctors, I show them a picture of Conrad Murray, and I go, that's what happens if you try to treat an addict by yourself. You will end up in a very, very, very bad place.
Okay, thank you.
You got it, Ariel. Thank you so much, and thank you for the work you're doing. Good luck with your career in physical therapy. Again, you betcha. The number here is, give it to you again. I'm going to stick around for a couple more minutes to take calls. The number is 984-2-Dr. Drew. That's the number 2, DRDREW. I have managed most of the stuff on the board here. I hope this is helpful to you because, again, this is a rather complicated topic, opiates and opioid addiction, and talking to young people about it. It's not a simple matter. You have to know how to talk, and you have to know what you're talking about. So don't forget what I said at the beginning, which was a narrative. So stories are very helpful. Somebody's story did not go so well, or maybe did go well, but it's a story that and for someone relatable, another young person's story, ideally, and that you can kind of take the heat off a little bit. Don't make it sound dire, and don't make it sound, you use a little bit of humor. That kind of thing can be very, very helpful. And then understand adverse childhood experiences. Understand that they often, if somebody's had 4 or more adverse childhood experiences, you heard me talking to Sarah, I think it was, that if you've had major trauma in childhood, you got to get that treated. You got to get if children are, young adults and adolescents are unregulated and their affect, their feelings are too prolonged, too intense, and too negative, that's a medical problem. That's not a parenting problem. And again, just like you would deal with any other medical issue, get them to the proper care. Let's talk to Mary here. Mary, go right ahead.
I was wondering if you could give your thoughts on what addiction versus dependency for chronic pain patients.
It's very hard to define, Mary. It's a difficult thing to say for sure. One of the things I always look at is what's the family history. If you have a first-degree relative with addiction, well, that increases the probability, at least by 50-50, that you have the addictive genetics involved here. Then number 2, I look at what is the history of childhood trauma. Is there childhood trauma here that is adding to the way pain is perceived? Doesn't mean the pain is any less intense than it is. The pain can be, there's a part of your brain called the insular cortex, which is how you feel. Literally the part of the brain that determines, there's much like we have the homunculi of our sensory and motor system across our parietal cortices, we have these homunculi in our insular cortex are sort of feeling maps, how the body is mapped out as a feeling, and what the, let's call it the affective component, the meaning of those experiences are. And if you have trauma, that part is on a 4-alarm fire, 5-alarm fire all the time. It's unregulated, it's miserable, it's horrible, and opiates help with that initially, but they don't really help with that long term. So things like Suboxone, other sorts of approaches can be helpful, and don't leave out the trauma therapy if those things are there. And if you get dependent with chronic pain with no addiction and no trauma, well, that's not, as long as your pain's controlled, who cares? So that's because it will not progress. The addiction is one of the things I think I didn't point out specifically is that addiction is a progressive disorder. So it's progressive use in the face of I'm sure I said this, but I didn't highlight it. Progressive use in the face of adverse consequence. Progression. If you're just dependent, you can have consequences, but it doesn't progress. And again, people can look like an addict and not be an addict. But in setting of chronic pain, sometimes you have to be dependent in order to get the pain under control. So again, this requires the skill of the caretaker. Let us talk to, here we are. I want to go to Sally. There you are. Hi, Sally.
Hi.
Hey there. What's happening?
I just good. Nothing. How are you?
I'm good. What's up there?
My friends are doing drugs. What do you think I should do?
How old are you?
22.
22. And what drugs are they doing? Sally? Oh, she hung up on me. Wait. Or she went, hang on a second. Yeah, she hung up. Seems like. Well, okay, so let's just use Sally as an example. So you got to find out exactly what's going on, right, with poor Sally. Again, is she intrigued? Does she want to use? Why is she hanging around with those people? What drugs are being used? Has she been experimenting with this? Why is she hanging with them if she's so concerned about them? There's a lot of things that have to be sorted out, and before you can help somebody, you have to get very, very, very specific. This is something that people, miss. To go, oh my God, don't do drugs. Zero effect. Zero effect. And by the same token, to say, don't hang out with those people, may not work. But certainly you might want to give a young person some alternatives if they are hanging out with folks like that. And sometimes they get involved with them because they want to rescue them. And they get sucked in themselves. Remember that plant? They get sucked into the plant trying to rescue. So codependency can be the problem underneath it sometimes. I'll give another couple minutes to see if any more calls come through. Again, that number is 984-2-Dr. Drew. And a reminder that the website is time2actmissouri.com. Lots of great information, lots of great data there, and lots of specifics about what's going on in Missouri. As I said, I was fishing around on the site and really impressed with what you guys have there in Missouri. And Missouri is, of course, not alone. This is a national problem. It's a problem everywhere. One of the really serious problems these days is that the laws are set up against us unless the child is under 18, where you this is one of the things to think about, as an adult, as a parent, you can put a child into hospital against their will if they're strung out on something and you want help and the doctor says they need to go in. You can just do it. But after 18, the laws prevent you from doing anything unless that person wants help. So it becomes about how do you motivate somebody to want help. And again, mental health professionals can be very helpful with this. If it is somebody who's just abusing substances and not addicted, just outpatient mental health services can go a very long way. If it's an addict, you're going to have to get involved in Al-Anon yourself, as we talked to Larry about a little earlier, so you know how to manage that person and help them motivate towards care. It's hard. And don't forget, 12-Step is out there. Mutual aid societies of all type are in every corner. Just go to the website. They will actually come pick up a person who's in need of help. They are free services. And as I mentioned, Dr. Kelly at Harvard Medical School has the Cochrane analysis now that shows it is as effective as any professionally managed interventions. Now, your child if somebody's an addict, they may be dependent and have withdrawal and be unable to stop. that's when the medical system gets kicked in. That's when you have to do it. And of course, if you know of a child in and around your vicinity is using a substance, by all means, get the naltrexone, which is available over the counter, that nasal spray, and carry it with you. That could save a life. Again, somebody who is not easily arousable, maybe sputtering in their respirations, that is a medical emergency, and there are Good Samaritan laws that will protect you against, if you are using with that person, say, protect you against any consequence. So please call 911, administer the naltrexone, and stay near that person as if at all possible. That seems to be the end of the calls. We appreciate it. We appreciate you being here. I hope this was helpful for everybody. It was a privilege. Again, I thank so much to the Missouri Department of Health and Senior Services. Thank you for asking me to come and speak here today. And don't forget that the website is timetoactmissouri.com. More resources and help are there. And please do share this video for anyone who is interested in learning more about opiates, opioids, misuse, addiction, and this landscape. And those of you that called, I appreciate the calls, and I hope this helped. And thank you for having me.